Yes, yes. So the idea here is that each group would come up and present their idea of a startup, and then everyone else will grill, not just the sharks. So all of you are going to be sharks. And then after each group was able to present and been critiqued, you go back and you try to address the critiques, and then you come back again and you will have a revised startup pitch.
Yeah. So we could either do this with the groups, like one group presents, we give feedback. That way everything's so fresh in people's memories, so we'll revise it and do it that way. So group one, if you guys want to take the stage. About 2 minutes. Yeah. Group one.
Group one.
Group one.
Stay there too.
And you guys will go up and present. Yeah.
Okay, we're group one. Customer service is often using bots now to navigate people through the Q&As that customers have, right? So a navigator is where this AI is going, right? AI can navigate us through information that we receive. Women often get information in their healthcare that they don't know how to navigate. And this is a big problem because they're not only deciding healthcare for themselves, but also oftentimes for their children, for their spouses, for extended family, like their grandparents, or their own parents. And so it does affect a huge ecosystem of people. So if we have a bot as a navigator, when we get healthcare information, either from our physician or from our test results, that bot can help us navigate through decision-making trees, whether we need to take a step here to go find out more information about x-ray result, or maybe our child was sick. So I know bots are pretty common, but I don't think they're really that common today in healthcare navigation for patients. So if we look at ways that we can use the data is to help screen through what are the most common questions, how can we connect the bot to the individual woman, and then that bot can be, maybe could be self-paid. I don't know, this could be an interesting idea. We didn't get to a lot of the funding models because we were either clinicians or data scientists or social scientists, so we needed an economist or a financial person to talk through the actual money side of it. But I know from working in health insurance that, of course, there's some profiles made for each of these care solutions and a code assigned to them. So that would have to be influencing the health insurance underwriting process to kind of include bots as a navigator that would augment or support human navigators that are already there, but they can't scale to the volume that we're trying to scale to. What was the last thing? Stakeholders?
Yeah, users.
Users, so it's the individuals. You have an idea on the other users since you knew the navigator role?
Oh, no, we were just talking about how navigators are often like hyper-local within a system. Mm-hmm. So there's the navigator for the hospital, and if you have a result, you can call them and they'll sort of help you work your way through the system to figure it out. So maybe this is a thing where each hospital has their own sort of sets of navigators that know their data and their pathways of how to accomplish something.
But it could go deeper and help you actually navigate outside the system if desired. So part of the an interesting solution, because we have so many different healthcare solutions available now outside of the traditional healthcare, it could be an opportunity for people to get access to more non-traditional paths of care.
Functional medicine.
Right. That, and then essentially provide opportunities or ways to take steps forward in other ways.
Time for questions. Thoughts, folks?
Okay, what if your navigator navigates a patient to an iceberg, like, oh, take this therapy, it must be good for you, and then the patient does, and it's bad.
That happens system here, and certainly I've tried many different things, as I think most of us have. We get to these icebergs all the time.
Okay, then like you guys as a company would be fine with that, just navigating the big.
No, I mean, we would have some sort of projection on how successful we want it to be, but also it's a complex ecosystem, right? So maybe just solving for one specific area would be the first step, but we're building off patient Q&As about what their health condition is and maybe the risk. And so if I at 40 can make a better decision for my health now, then maybe that would prevent future health issues.
I think you'd have to put clear guardrails in place, right? So when you're building out a model, you'd have to do lots of testing to see what the output would look like, right? But I also would think that at some point, depending on where the chat stops, right? Like there might actually even have to be a regulatory step there because of the recommendations you're providing. Even though this is more of a navigation, so you as a consumer, right? This kind of empowers the patients a little bit too, to be able to make informed decisions, but actually make decisions outside of what's traditional. And so in some ways that actually might be better, right? Because you don't even know what's available to you. But to your point, like, and to your point, like that happens today, right? You think about like people are posting on social media all kinds of crazy stuff where you're like, you should not do that. But it's not like someone shuts them down, like it's just there, right? And I would say as a company, if you're gonna create something, there has to be like an ethical line where you have to decide and you do enough testing to ensure that your outputs aren't gonna send people down these unresearched rabbit holes, is maybe what I would say, is that maybe you could create some guardrails around all of our recommendations would be backed by research at some way, and then you can kind of set a limitation on what's considered good research and bad research so that the recommendations you're generating are not that crazy and off the wall or dangerous.
Yeah. There's also a difference between recommending or getting somebody into a therapy and helping them take the next step in understanding their health, right? So if I get a health result that is concerning, it's flagged red, it's a cancer screen or something, it's often hard to understand what that actually means. And a navigator can help you say, okay, well, if you have this result, the next test that usually happens is this test. Here's how you would go about scheduling that test. Would you like us to help you schedule that test? As opposed to, please go take this chemotherapy right now, right? Which would be a much bigger sort of like leap that we shouldn't really be doing without that. But navigating is like this interesting middle ground where it's not health advice, it's helping you take better care of your own self, and it's allowing you the opportunity to more, to interact with the healthcare system in a more sophisticated way. Yeah.
How different is this from ChatGPT?
Oh yeah. And it's yeah.
Well, because I'm calling in the medical website or the medical procedure, and it's not from a third party, right? It's part of the medical process.
Then
Not everyone uses ChatGPT, but they do use their healthcare provider.
That's a fair question though, like how is it not just a wrapper on ChatGPT?
Yeah.
Yeah.
I think it depends on how you deploy it, right? Like if you're, I mean, this is just an idea. So like if you're going to deploy it within a specific health system, then it only pulls from the, right, like a closed data of these are all the providers we have, this is how our system works, these are the recommendations we give you. If you're going to think about it from like a ChatGPT perspective, like yeah, I've done it before. I think ChatGPT actually does some really great recommendations, I will say. But
Yeah.
sometimes,
Yeah.
truly, right? But like, I think there's what I find is interesting with ChatGPT outputs is when you don't have enough context. You don't give it the right context, because then it does send you down the wrong rabbit holes. And so knowing how to ask and or answer questions in a specific way to get you to the answer that you're looking for, I think is some of the challenges of using something as open as ChatGPT to get an answer from a pretend medical provider. I don't even know how to categorize it.
Yeah. Yeah, but you could imagine a spectrum between like a system that only worked in this hospital for this one problem,
Yeah.
and then a ChatGPT that would sort of do anything. And somewhere in there is a medium ground where navigators are currently what we use to solve this problem. But they're like a human navigator, like you call up John or whatever, John helps you schedule the test. I don't know.
Do people know what navigators are at their healthcare provider?
Yeah.
Some of you do.
And like it's also like very person specific, right? Like sometimes it's just if you're lucky enough to get the one person that's been doing this for years versus like the new person, right? So if you could actually standardize that, where that wealth of knowledge from having done that for so long is in one place, could actually be really valuable for a patient. Now that I think about it.
I guess 2 points. One is there's a Medicare billing code for navigators, so you can monetize easily.
Yeah.
And if you qualify, it's free for the patient. I'm sure it's true for other types of insurance. And then two on that, the difference is that you have a repository of like localized knowledge. Just like 211, you call 211 is different information than like necessarily ChatGPT, because you have all the nonprofits, all the pathways, all the workflows, all that stuff. So that's what makes you different than ChatGPT.
There you go.
Thank you.
Thanks.
You can join our team. Would you like to?
We have candy.
So, just to build on that, on the financial side, I should have traded, right?
Yeah. Would you like to join too?
So you should see there is a company here in Silicon Valley called Neatly Health. Have a minority position there. So they're trying to do what you guys are doing, but the way they approach it is they're monetizing the data. So they identify the data, and the way they're better than GPT is you bring it with you to your appointment with your doctor, it records it, right? The provider has their own, whatever is Kaiser, Dragon, what have you, but you as a patient have your own. So it learns from you and helps you navigate, helps you figure out whether Medicare, Medicaid, payments and what have you, and helps you prepare for your next meeting. So you might want to look at it.
That's cool.
That company, that's
What were they called?
It's called Neatly Health. It's a small startup. Yes.
Cool.
Yes.
So that concludes the pitch. We'll be moving on to group 2.
Thanks,
you
guys.
everyone.
Appreciate it.
Good job.
Oh no. So two. I come with something else. So I won't talk on this one. Oh yeah,
Yeah, that's okay. Oh my god, I guess you're doing something. Yeah. Hey, come on. You're part of the group.
Am I Leo?
Yeah, yeah.
Hey, bring out the muscle.
You don't get to escape the grilling.
Yeah.
Alright. So you have 2 minutes, guys.
So we were discussing about how we can make this happen more efficiently. So one good point you suggested was to introduce a scribing tool. What you suggested was like 2 agentic systems, one from the patient side, one from the provider side. And on behalf of the patient and the provider, these 2 agents will help summarize the entire communication, like what were the internal communication. Let's suppose I am the patient and I have the scribing tool or the device which listens to my daily communications, and based on that, it when something happens to me, it will try to go through all the communication. Let's suppose my BP was high or my anxiety levels were high. So it will drill down towards that particular communication on that day to check like why was this happened. So it will understand like, okay, there was a small fight in the house, because of these reasons this person's health was deteriorated. So such type of 2 agents, they can come into existence and they can communicate on behalf. And when as a person I go to the provider, at that time along with V2, those 2 agents are also in the room. So they will help to drill down into the more information apart from the EHR records or the lab reports that we actually have in place. Because the lab reports and all are just the results of some calls. But what can be the actual reasons can be demonstrated by those 2 agents. Like, okay, this day that those things happens, and this could be the potential reason for the your results. So this was one part of communication. Second, we went down to issue where language could be the barrier. So so let's suppose mostly the LLMs are trained and the models are trained on the English. So if there is some other language in which the person is trying to speak, so which is actually a research project that our university is doing. So that person is trying to speak in Spanish and the LLM is trained in the English. So in English, the communication is happening properly, but when Spanish comes into picture, the LLM cannot understand and it cannot give the good answers. So this can be a potential barrier. Then we jump to other point, like how can we solve that, and the guardrails that we need to keep to address these issues.
So the idea here is to bring the scribe to the home. It's reimagining the patient encounter. Before the patient even goes to the doctor, the patient and her or his family already communicated to the scribe that will capture the richness of the symptoms. And then that agent reports to another agent and would try to extract. But we don't lose any information because most of the time the information is lost. You archive all this information for future retrieval if that's going to be needed in future decision making.
In terms of payment system, that was a challenge. I think it does at some point require both the hospitals and the users to pay for it. And then the data sources. So like one of the big challenges was like where do we get this data from? That was a question that we were still left with.
And that's because we are connected to the provider, we're using whatever platform and scribe they have. So it should be a RAG, everything is contained there, hopefully reduces hallucinations. So now you have a patient who's paying for this solution with an agent interacting with what the provider already have, and adds a layer of governance and compliance on top to make sure it's HIPAA compliant, is de-identified, and what have you.
So open up.
Can I?
Please, Kathy.
Yeah.
Yes.
Oh, I just wanted to add one additional thing, is trust. So when Leo talked about the patient encounter actually happening at home, that is, can you all hear me?
Yes.
Okay. The patient encounter happening at home in a safe environment, that builds patient trust, and they're more likely to actually say certain things when they're in a trusted environment. So that continuity of care between the patient encounter in the hospital and also inside of the home is bridged. That's the only thing.
So now we'll transition over to the audience, or the sharks, and we'll rapid fire their feedback.
I don't know. I mean, Kathy just mentioned how in the comfort of your house you may talk about things that you wouldn't normally talk about. I don't know if this is just me. I'm too Mediterranean. But whenever I go to the doctor, I can tell by their face if what I'm saying makes sense or no, and that may me lead to say some things differently or extend my response. If I'm at my place, and then you have the layers. The way I saw it was like layers of perception, of interpretation. So on the one side, the patient is alone by itself, and given their understanding of what they feel, telling that, and then at some remote point in the future, it's going to be a physician reading that and making an idea or a subjective perception of what the patient wanted to say. So there's a gap there in the communication.
So this is why the agents have to be part of that patient encounter, because they will surface whatever requires more nuance. Like, hey, this was mentioned by you, but it's not really as explained as it should be. Maybe that's one thing that you can talk about now that we're all here in the room.
So who has gone to the hospital lately, or dentist? Don't you guys get a survey? Complete all of these things? So what Leo is proposing, which I think is pretty clear, instead of getting that little survey, which we all hate to answer, just to save 5 minutes, we could do there because we're going to be sitting there for more than an hour. We get that at home. So he's talking about the community. I'm there with my mom and my spouse and the kid. So there's going to be a lot of context that come there that of course needs to be clean on terms of compliance, HIPAA, what have you. But then that comes with me. We're not talking about disintermediating the physician, the clinician, what have you. So once you go there, your agent already put those contexts, the two agents shake hands. So now in those 15 minutes that the poor clinician is trying to do magic, there is a lot of understanding, a lot of context within the two systems. So it's kind of, that's what this solution, I think, is what we've been discussing, right?
So Kaushik had something to say, and then we'll close out the next group.
So Rolf, I think you know better than anyone how deeply embedded these LLMs are with structural bias. Did a presentation on it a couple months ago. So if, in order to sort of mitigate this effect, are you guys proposing like a closed loop of data? In which case, how do you, what's the start point? Where does the data come from? And how do you prevent it from becoming sycophantic if it's closed loop?
Yeah, I think that's a great point. I think data streams and who generates the data and where the data is being generated is something to think about. And while technology's not here yet, maybe this could be a way to encourage more people to be involved in the data generation process. So maybe the models aren't working well right now, and that's something that we recognize and actively think about. But maybe technology around that, the systems around that, allow us to get data that is different from what we have today.
I have one more point. Like the consent issue can also happen here because whatever it is scribing, for some scribing it can have the person has a consent. For some part of the communication, the person or the patient might not have consent to get scribed. So what to get scribed and not to get scribed can also be a complex question of guardrails.
What I just wanted people to, another point to think about is when you're building a product, think about whose jobs are going to be displaced. So how many people are going to be unemployed as a result of your tool? Because I think that's part of the report card, the sole report card that we're trying to mention.
I would just say replaced, meaning replaced in a new place.
That's true, yes, yes.
I think we always talk about it very negatively, but
Yes.
reskilling is part of any job career cycle. So how do we reskill them for a new position?
And I
Like
think that's where the
in the
problem is
family
now.
of positions, yeah.
We don't even know what those new jobs are going to be.
Right.
And no one is preparing, no one is providing space for us to reimagine what new jobs can they occupy.
Can I just add something to that? I agree that people are going to be replaced, they're going to reskill, but that process of reskilling is not equally achievable by everyone. And it affects people in different ways. Like I may be able to reskill very quickly, but someone else might not be. And I think there's some early reports showing that once again women are going to be less likely to be able to reskill as quickly, and they're going to be more affected by those AI replacement jobs. So this is just
Which I think is also, like, it's interesting to wonder, like, where did they, like, what is basing those claims off of too, and,
I'd say women are intuitive for people skills, and they actually have more people skills that will be demanded. So if men are writing those articles, then say that.
I agree with you. It's based on the job that are going to be replaced and the job that
All right.
people already.
Good team.
Yeah.
Yay!
$150 million.
All right.
All right, we are team 3, and we are addressing the problem of friction in healthcare. And the problem of friction is that as a patient, my insurance company often denies or delays the care that I want. As a provider, the payer really makes it difficult for me to provide the care my patient wants and really deserves to improve their health. So what we are creating is an AI agent that offers both patients and providers ways to overcome friction with payers. With patients, the agent will really help the patient connect with providers who deliver the type of care they need, and it will help it'll take all the friction out of the patient's life by working with the provider in submitting evidence to the insurance payer to get patients the care they need. With the providers, the agent will bring more patients through the door, through referrals, and help the providers work with the insurance companies in submitting to them evidence that will reduce the friction life cycle and accelerate, provision of care. We are calling this agent ally because it's fundamentally an ally for patients, for providers. And right now you're questioning, is it stacked against payers? Actually, it's an ally even for payers. A few years down the line, we will take evidence to them, the payers, that this type of exchange actually works. It brings down costs that payers and patients actually pay providers for the care they need. I will turn it over to my team members to describe this further.
Oh, I'll just give an actual example that happened in real life to make it really concrete. So I was on LinkedIn a few months ago and I saw this post that went viral. It was by a Stanford professor who teaches clinical science. So he had lung cancer. He actually taught his case and was like famous, published on New York Times, whatever. The cancer was in remission. Then it came back and he tried to go to the best doctor. The medicine, the treatment got denied by his insurance through Stanford Healthcare, through Aetna. He was so desperate, he went on LinkedIn because he was like, if this gets denied, well, I will actually die. So can someone please just help me figure this out? Because this is like, imagine it's you. It's literally the last thing that you can do to save yourself. And it went viral because people were like, you should not have to go on social media to beg to get treatment. This is so inhumane. This is post-Luigi era. So what ended up happening is that because of how insurance works, literally insurance, what they do is to just deny you. Only 1% of people ever appeal. 80 to 90% of the time is overturned. People don't know that. There's actually a third-party audit process. There's like a whole administrative, people don't know that. So then they just accept that your insurance doesn't cover this and then people die all the time. So this basically is just using AI at scale to do all the paperwork to help people get the care that they deserve. And this person actually did get the care. He paid $40 for a startup. The claim did actually get overturned and he was able to get the treatment. So for the provider, they make a lot more money because obviously they got the insurance to cover it. For the person, they're saved. And for the insurance company, this is just friction that's in the system that through AI basically is counteracting like a separate force. So we're just doing this at scale to do the documentation. Patient never has to worry about it, and then they get the care that they need. So long story short, it's basically that very process scaled. And then the business model is that you can imagine for the provider, for the treatment, it's millions of dollars. So we take a percentage. For the patient, they don't have to pay anything. If we help bring additional revenue for the provider, take 2, 3, 4, 5%. They already do this for something called revenue cycle management, which is they take like all your medical bills are coded by hand by a human who find a billing code and then submit it to insurance. So this is just a service just like that on top that mitigates the whole thing, and I mean we're basically profitable day one. So yeah.
But you're saying today they only approved 1% of the ones?
No, so they
they'll wise up to that pretty fast.
100%. So what
that's like 2 cases and they'll be
100%. So what they do, depending on the insurance company, their stats for this, UHC, United Healthcare is the worst, which is why the whole Luigi thing. But basically they deny at scale, and then hopefully that most people don't know you can appeal, so they don't appeal. There's a separate process as an independent party that does the appeal, which is like a separate doctor. Imagine not UHC, but an actual doctor.
Yeah.
So that is where most of the 80-90% overturns. So after that, you can go up one more layer. There's a regulatory body. Above that, there's actually a lawsuit that you can do to go to like a federal judge. So people don't know about this process. They just think I was denied. I'm doing something wrong. So it's completely helpless. Not unlike the Navigator idea actually.
Yeah.
So this basically just makes it so streamlined. They don't have to worry. Like this is like okay, if I actually this is not a frivolous service. It's actually clinical sound. I actually needed to survive. Someone should just take care of this.
Question over here.
Sorry, I'm not sure I understood that part. So for funding,
Yep.
you want the provider to fund this? Or
So
will they also?
imagine for the provider, right? They make money when you get the cancer treatment. If insurance doesn't pay for it, they don't get money. So from their perspective, if they were paid $2 million to provide you treatment, they are more than happy to give you a few percentage. But what that percentage is negotiable. But today they already pay a percentage to do basic building code. So you can imagine this is just another way that helps them get revenue. It's literally a term called revenue cycle management. As like I don't know. So it's kind of in that vein, but takes it to the next level.
We also discussed the option of getting patients to subscribe to this product during the insurance cycle, so the patient can pay out of their HSA. They can pay dollars based on their own anticipated level of healthcare spending and conditions they have. We could charge them different tiers of subscription because that's the amount of work we'll have to do for the patient, and the patient will see the returns by the end of the year in getting the care they need and getting it sooner.
So if
Yeah.
I was going to say, if you go, for example, to the hospital and tell them, here's a product you can offer to your patients, and now the hospital suddenly has an agentic workflow that is going to, appeal every decision that is being made by the insurance companies, do you expect that this may have an impact on insurance companies wanting to contract with different hospitals?
1,000%, and this actually already happens at scale, not through AI, but so because of the reimbursement rate for Medicare and Medicaid, there is a whole separate industry in the last few years. So there's a new bill. There's a bill called No Surprise Act. So that bill actually, what a lot of providers, a lot of doctors did was at scale, go through these third parties to appeal every single possible thing, so that for the same surgery they get millions. So you are absolutely right, and this is why there's such a tension always between insurance company and provider. There's a reason the prior auth exists, because without it, it's like here's a code, you need a surgery for your code. So it's a very healthy tension. So to the second team is going to be agent on agent for sure, because that's the only way in which you can actually do this at scale in balance. So then the question is, what is the framework upon which we believe there is clinical evidence? So that is something that's outside the scope. But you're absolutely right. 5-10 years from now, absolutely at scale, it has to be two separate agent systems, and they will have to counterbalance each other. Because if one side is not using AI, it will exactly the system. So you're totally right.
And by design, our system is going to be is going to help patients and providers pause and reflect through this process, right? Through useful prompts, through appropriateness guidelines, because that's what we use for submitting as evidence, right? So if something doesn't rise to the level of appropriateness, it's almost a point of reflection for both the patient and the provider. Do they want to proceed down this path or not?
I guess there's two things. One is calling an insurance company as a provider and explaining why I need my patient to have this life-saving treatment is incredibly soul-destroying, for lack of a better word.
Absolutely.
So to have something else do that for me is amazing, and not that I get paid for services, I'm an ER doctor. If I did, I would certainly give you some of that money because it's important. But that last part, I think, is a little dangerous, right? We were talking earlier about when measures become sort of what you're going after.
For sure. Yeah.
So I have a patient who comes in that's been in a deadly car accident, and I need to do a CAT scan of their head.
Yeah, that's a good point.
And the order right system says I'm not allowed to do a CAT scan because they haven't had this headache for more than 2 days.
Right.
And I'm like, okay, but
Absolutely.
they're dying, and it's a car accident.
Yeah,
And so
indeed.
whatever it is, so I would just push back a little bit on the fact that if it doesn't rise to significance, it means we need to slow down.
Yeah.
Sometimes it means the system's not measuring the right thing.
It's a great point.
And
Great point.
maybe there's carve-outs for this or whatever we're designing, but it's hard to agree upon what right looks like.
Yeah, indeed.
And you can't really build this till you understand what right looks like.
Yeah, to answer that, I think we can never get to perfectly what's right, because imagine 30 years from now, maybe what looks like a disease is hasn't even emerged yet.
Yeah,
Building system, there's no way it can catch up.
Yeah.
So it's more like moving towards that direction where it's less wrong.
Yeah.
Less wrong all the time. So.
The only other thing I would say would be, I would actually be a little hesitant on relying on the provider to pay for the system. And this is not everyone, it's probably an edge case, but I know there are providers that you could do ENT surgery. You can do the same surgery for a patient, one charges 10x more than the other. And so that ENT surgeon will always choose the higher one because they
Hi guys, we are group 4. What we are building is a women's health intelligence platform. 50% of the population is women, but they have 25% more adverse outcomes in healthcare than men. They also have 1.5 to 1.9% more chance of adverse effects than men. Why is that happening? Well, women's healthcare is ignored. Their complaints are ignored in healthcare systems. Ignored complaints leads to late diagnosis, and late diagnosis means missed treatment opportunities. And obviously that's a outcome that keeps happening and happening. So we have an idea, which is we would build personal agents that help women to inform their complaints about their situation, either a new drug or a healthcare condition. And the AI sits on their phone, identifies patterns, and creates an intelligence that is then shared with the healthcare provider, the doctor, for reporting purposes, or eventually we could build it into a pattern where we can share that into an evidence-based care. The way we would make money out of this is we provide the service for free for the patient because we want to keep it that way. Data stays on the phone. It's not processed outside or in the cloud. It is personal. But we take the patterns out of it. Okay, 18-year-old female of this origin, of this race, is suffering from these kind of complaints when taking this medication. Those patterns help create a network that either helps in creating case studies or clinical trials, or even we can charge the big pharma, on a subscription basis or in some format to generate revenue into the business. We think this is going to be quite a pretty big idea. It's not a niche because, as I started off with, women form 50% of the population, and if we do this right, there are other healthcare conditions where patient-reported symptoms could help in forming an evidence-based care mechanism driven by AI agents and anonymizing the data, creating a way to save the information. I would open it to others too.
Yeah, I think we first thought about it based off of birth control pills. If you're a woman, you know, birth control pills has a lot of side effects that are not studied, almost little to none at all, and it affects your mental well-being, your physical well-being, your interactions with other people, and different pills have different side effects, and kind of based off of that, we decided that we would kind of build a database or a system where we can collect this data from users, ask them to report what are the side effects that they feel after taking specific pills, and then kind of reroute them towards specific alternative solutions. But yeah,
That's us. Yeah, I think that's exactly right. So data is the business model, but we want to make sure that we have enough number of customers in the first place. It's like the Flatiron situation where you need to have we have a cold start problem, having enough number of people reporting what they are going through, and then the business actually becomes quite viable because then that for a particular condition, I don't know, there are different conditions here. Birth control pills is a good example. That could be the wedge where we start from. There are different birth control pills right now. That could be the population we target, maybe in California state, focusing on that particular market opportunity. And then we reach out to pharma companies that are building those birth control pills as the initial market opportunity. But eventually, it could apply to cancer therapeutics. There are women who go through some medications don't work, pain won't come down, and doctor thinks that you are more anxious than suffering from pain. So, I think there are so many implications of this kind of opportunity, but basically the thought process is, women health is being ignored because there is no right opportunity to voice their pain in a right way. So the best things we are thinking is everyone has their own phone. They can report those outcomes in their agent. There's no stigma or nothing to be worried of. The voice is quite as clear as it can be, and then use those to create patterns to inform evidence.
Yes, I'm going to play devil's advocate here.
Please begin.
Let's imagine I have something against you. The way you're presenting it, if I wanted to really teach you, I would say, if I'm following you well, you're saying that the system overall is not interpreting well what women say, right? And in order for them to be understood, you want to provide a layer of agents built on data that is largely created by male from Western countries. So are you expressing implicitly that women cannot speak for themselves?
So where is data from male Western countries coming?
Well, most of the training data for this agent comes from.
No, we are training out of patients' reported complaints. We are not training out of public databases here. So we are not saying a particular birth pill has these symptoms. Then you are right, you have a point. We are saying women report their symptoms. So like, okay, I'm a woman right now. I took a birth control pill. I have these symptoms. And I'm going to report that on my personal agent. So it's not coming from like a existing case study that in which case you are absolutely right. But it is actually coming from patients themselves. So it's patient-reported outcomes forming into an evidence-based care.
So how do you get critical mass? Because you're going after end users.
We are going to make it easy for colleges in the first place, universities, as the starting point with this use case. And we are going to build the evidence that this kind of approach is going to make a huge difference in the healthcare system. And as we're giving it for free, I think there is going to be no blocker or adoption barriers. But I think we would be open for some ideas there.
Yeah, this is not just data from the agent. We can integrate this with the existing EHR systems where we can extract data from physician offices and clinical systems. And this includes both sides of data from the user as well as the EHR systems. So this combined, it gives a whole 100% thing without any ambiguity.
How the system will treat the silent system, like silent symptoms that are happening? Let's suppose I'm taking the birth pill. I don't observe any symptoms. But after 15 or 20 years, I'm not having a baby, but I did not report that. I want to get a cure on that, but I remember that I took a pill or I took a pill, but I didn't see any symptoms. So even if I'm using the system, I will not be able to get the curated experience of the entire, so the purpose will fail there. So in that situation, what would be the fallback, or how will the system be placed? Because mostly the symptoms does not show up very rapidly, instantly, but by the continuous taking of those pills, and most of the 80 to 90% of the systems are silent. Like for example, corona. Mostly people had the issues, but there are some cases in which there are silent symptoms, like people directly choke the heart, that no symptoms. If I had a system, I can report, but what if I myself am not in a capacity to report that symptom?
It's a very good one. Generally, there are markers that are both like almost like a longitudinal case study, right? What you're talking about is over a period of time, what kind of changes happen in a particular patient because of some intervention. Sometimes we don't know. Sometimes it is about being able to create those patterns in the first place, create those data points. Like for example, totally different context, but Johnson & Johnson released a knee implant a few years ago, and that had some adverse consequences on patients. Not immediately, but in 3 years period of time. And the only way they knew it is like whoever was getting treated with this implant, after 3 years or like over a period of time, they were complaining it, and somehow they were able to retrospectively connect the dots. Okay, everyone has a commonality that they had this implant in their body. So there's a very good point that all symptoms don't come out quite immediately, but I think data collection is the first step to solving that problem. And his idea around combining with EHR-informed data points, like how the health reports are coming out, and combining it with patient-reported symptoms could be a solution. I'm not sure if you had any other idea there to solve for it.
No, I don't have anything, because this is the issue, like, no all symptoms are provident immediately.
Correct.
And the point till which we come to know that, okay, this was the reason, it's already too very late and the damage is already at a potential high. So we cannot treat.
Yeah, for that patient, yes.
Complete loss.
Absolutely.
So whatever the thing is, after grabbing such type of data, after that loss only we'll be able to treat future people.
Correct.
But that people are gone.
Yes.
So that will cause the initial distress. So coping up with that in the future, even if after we have the data, would be a huge effort, because the distress is already in place.
Yep.
With the application. We cannot explain like, okay, we didn't have the data. We will grab the data, we will analyze after 15-20 years what are the side effects of this, if till we can come to know about that, and after that. But till then it's already late.
Yeah.
People would already falsify the application.
Yeah, if they are reporting to the system very late, so that is not something a system or anyone can, even physician himself cannot do anything if they are coming back after 20 years.
These are great points, and I think that we should make sure we have room for the next group to present, and I'd love to end the debrief, chat a little bit more about this stuff. This is really interesting.
All right, so we're group 5. We explored some different problems and things that we thought about addressing, and we landed on the idea of trying to help with specifically patients that suffer from dementia and cognitive decline. So this is a very large population, and it's only growing, and when you look at the problem space, there's a lot of problems, but one of the things that we really narrowed in on is facilities like senior living facilities or the VA, where they do have a lot of dementia patients, and they have staff that needs to support those dementia patients, and that's a very difficult thing. Both actually, what is even the goal here? Like my personal case, I have a grandfather that's in the VA who has dementia, and I think the main goal for him would be just to be comfortable and content and have some level of, baseline satisfaction and happiness, and that's great. And I think he's close to, maybe he might be there. But on the flip side, the actual caregivers and the people that take care of him, that's the side that we narrowed in on, where we think there's a lot of room to improve. I think we all probably know that it's very difficult to care for dementia patients, and specifically because of the cognitive decline and issues on that side. So we were looking at how could we use AI to essentially help providers and people that interact with these dementia patients as kind of like a Duolingo kind of coaching app, where they can actually learn how to better engage with the patient and protect their own mental health and well-being. Because when you look at the turnover rates, a lot of the professionals that do help these dementia patients, there's a very, very high turnover rate, and it's one of the most unaddressed problems. So essentially providing something for them where they can basically have an idea of, this is the patient, these are the things that they struggle with, you might face these issues, and they can engage with the patient. The AI will not be in their face telling them what to do or anything. I think it's important to have a real natural engagement with them, but once they leave, they can, once they stop encountering with the patient, they can get feedback on what they did well, maybe how they can improve, kind of helping them emotionally be able to weather the storm of caring for this patient over a long term. So that's the start of the pitch. And then, I guess the other thing I'll address is the big question here is who's actually paying for this? And I think that the person that would be paying for it that's most immediate would be the facilities that are trying to prevent work turnover. Each time that somebody leaves, then they have to go find a new replacement, they have to train them, and the cycle continues. So being able to provide a system that the providers actually feel like they're more equipped, better trained, and are feeling better emotionally at work as they interact with the dementia patients, proving that that actually retains employees and improves the overall experience for both the people that are doing the work and also the administrators. And there's some opportunities for how you could actually get some reimbursements from Medicare specifically. That's kind of the start to our angle. Anything else you listen?
And I think, from a compute standpoint, one of the things that we talked about is that, especially for something like caring for a loved one with dementia, we think that the data should be driven from a personal experience standpoint. And we talked about how some members in our group had experiences with friends who had family members with dementia, and how they struggled to find solutions. So we also think that our data set should be open access. We will take all necessary precautions and have people consent to their data being published, and we will have de-identification protocols if they wish. But we do think that data of this format should be available publicly, because more systems like this should exist. And caring for people is never a bad option. So we want people to have access to data of people's lived experiences, not synthetic experiences that are generated by some math algorithm somewhere, but real, genuine human experiences that can't be mimicked. So yeah, from a compute standpoint, that's kind of where we stand.
I love this. I've done so much deep research on this. So, a couple really interesting things that I would think about is there are some really cool VR experiences for caregiver training, which I would kind of recommend. It's pretty neat. Where I think Endeavor does one. There's a couple of mine does one where it creates the experience of what it's like to have dementia, so you can understand when there are hallucinations happening in the room, or the way what causes them to have those types of behaviors, right? So I think empathy training is really important from a caregiver perspective. I've actually done some research on Montessori for aging and dementia, which is this really amazing. It works really well. So I would just consider looking into this. Really cool. And we think about family caregivers actually as your first customer, not necessarily staffing. So there are a couple of reasons. One is the margins are already super tight in those types of facilities, and so in order for you to really demonstrate your return on investment, you have to really prove out this is effective for their staff with dementia, right? And you're also making the assumption that the staff either still actually wants to be there, so that's something to consider. But family caregivers are the ones, if you dig deep into a lot of the forums, caregiver, Facebook groups or Reddit, it is such a wealth of knowledge of understanding the pain points of family caregivers of people with dementia. And those guys will, if you gave them a solution like this, they would jump on it in a second. Because a lot of them, they're thrown into this experience without any expectation. They didn't even know this was going to happen to them, right? And so, care very deeply about this area. So, I love the concept of that. I think it would be really great, but I would start with family caregivers first.
That's a great point. Yeah, we were trying to figure out who we would go with between the business side or the family side. I guess the only concern was that on the family side, the data seems to show that a lot of the caregivers are lower income themselves. But yeah, I think maybe $15 a month or something, you could form something. Yes.
Yeah. So on that line, in Medicaid, there's ways to reimburse family caregivers. It's just most people don't know about it, but you can bake a lot of these caregiver support as a whole platform. Because like what she was mentioning, you just kind of enter it and just the whole world is different. Yeah. So there's a whole entire ecosystem support that's possible through the platform,
So scaling is going to be an issue because now you need to go after the caregivers. So how do you think about that? I encourage you to kind of.
There are family foundations who really pay for this and put a lot of money because this is a key area that we're seeing dementia. Early stage, early onset dementia is huge. So I would encourage partnerships to get funding there. And if you could that could also help really build this into a kind of a very helpful
backbone for research studies too.
Yeah. Yeah. That in terms of the, like we were saying with the data side, it's very sensitive in healthcare in general. Like, what are we gonna do with this data? How are we gonna make money on it? So something like that, being able to give it to the right groups to actually do good work on it, could make it more sustainable without losing the mission.
NIH has had groups on dementia and other components. I think one component is actually surfacing to understand what previous research has been done, where has been the promises, and then the use of multimodal data. Now you have images, you have feedback from facility, you have feedback from patients. The core question is, as there's a tool and there's notes being captured of data, there's going to be variability across your dementia patients. How are you going to capture that? And how are you going to measure improvements if you plan to measure improvements with using the tool? Because if you want to use impact, what is your impact or improvement that you're targeting? Is it change in symptoms? Is it more interaction? Is it like what type of interactions?
So yeah, I think like the goal would be to make this dynamic, and rather than when you're going to have a child, you read a book before a couple of books. Like here, the goal would be to have something similar, but in a more dynamic way, where you can prepare for like dementia events, and you know how to manage like your family member, or like what to expect, how to respond, how to kind of debrief, how to feel about it afterwards. And so we would like integrate like research, subject matter experts, and the AI would just be a way of accelerating this kind of platform. It would make the training much more scalable. And we're talking about dementia here, but we could expand this to other very complicated diseases and health conditions. It could be like a terminal cancer or other psychiatric conditions like that caregivers and caretakers have to deal with.
But I would add also that there is a component of, yes, educating and having a way for people to kind of debrief and understand how to take care and how to handle these situations. That's an intervention of an educational or a component of support. But there is a component of how is your model helping monitor or helping intervene early with patients with dementia to avoid the progression in dementia to be worse, because these patients cognitively hugely have reduction. So big question will become, what is your model or value bringing back to help the providers within a facility or the caregivers to be able to intervene early to ensure that these patients, for example, their cognitive capabilities is not actually deteriorating. That is going to be an add-on.
Yeah. One last thing real quick, and then we'll move down. Yeah, go ahead.
Okay, well, I was just going to say, so I'm actually on the senior care commission at the county level, so another way is just local government who are partnering with all these organizations. But an easy way to monetize is that actually a lot of these long-term care facilities, if you refer to them, they will pay you referral bonus. Similarly with like all these home aids, so there's a whole ecosystem where the money definitely flows somewhere. If you're at the center helping caregivers, I don't worry about you getting paid.
Yeah, so I guess you could almost do something where the family joins the app or whatever it may be, and then over time maybe the app helps connect them with a facility that can help with as the condition maybe deteriorates, and that's a great idea.
Great discussion.
Thank you.
So just because of time, we're going to be pausing on the debrief and formally not doing that, but we'll allow for conversations to flow afterwards during our breaks and sessions to kind of allow us to bring the perspectives that we have from, project out. I've kind of experiences, both being on the perspective of trying to put together an idea, share an idea with a group of people, and then also on the other side of evaluating an idea and what those dynamics look like and feel like as a reminder. Because sometimes, all of us bring different perspectives, and we're so close to one kind of perspective of the table of these conversations. It's important and good to step out of that role for a little bit. So some of the things that I've noticed, and Richie, if you can feel free to add on, were the dynamics of vulnerability, and it felt like, when we were up there, I never heard anyone up here say, I don't know, and leave it at that. So I know we had talked about that briefly in the morning, but this is one of those things that in that dynamic, you oftentimes are, when you're putting something together, building something, it puts you in a position where you feel like you have to defend it. And oftentimes from the audience, it's people like that have a lot of different great perspectives and a lot of experience in a field, and it may not be the entire exact thing, but an angle of it that have something that they can add on. And so I think building an environment of vulnerability to invite perspectives in a constructive way is something that I noticed could, in this environment and dynamic, be built upon more.
Yeah, definitely. I want to thank everyone here in this room, because as someone who came to this country not that long ago, I have to confess that I've missed a lot of things that you've said just because I was trying to digest information and all the good ideas that you have had. And it's clear that there was a lot of thought put on every of your speeches, of your talk. So thank you. I really think if we could expand this to more environments, if we could make this part of our daily workflows, just imagine what could be true.
So let's continue bringing more perspectives in. And with that, we'll jump into our brief panel up until about 3:30, and then we'll jump into the next session, the reverse Shark Tank after that. So we'll start getting set up. We'll have about like a couple of minutes if you want to go grab coffee, go to the restroom.